Hello everyone and welcome to today's webinar where we will be going over acute stroke and ACLS. Stroke is a condition in which normal blood flow to the brain is interrupted. Strokes can occur in two variations, ischemic and hemorrhagic. In ischemic stroke, a clot lodges in one of the brain's blood vessels, blocking blood flow through the blood vessel. In hemorrhagic stroke, a blood vessel in the brain ruptures, spilling blood into the brain tissue. Ischemic stroke and hemorrhagic stroke account for 87% and 13% of the total incidence, respectively. In general, the symptoms of ischemic and hemorrhagic strokes are similar. However, the treatments are very different. Clinical signs of stroke depend on the region of the brain affected by decreased or blocked blood flow. Signs and symptoms can include weakness or numbness of the face, arm, or leg, difficulty walking, difficulty with balance, vision loss, slurred or absent speech, facial droop, headache, vomiting, and change in level of consciousness. Not all of these symptoms are present, and the exam findings depend on the cerebral artery affected. So first, you want to activate the EMS. For oxygen, use 100% oxygen initially and titrate when possible. Finger stick, check glucose. Hypoglycemia can mimic acute stroke. You want to gain a medical history, determine precise time of symptom onset from patient and witnesses. Perform an exam, determine patient deficits, gross motor, gross sensory, and cranial nerves. Seizure, institute seizure precautions. Gain IV access with a large gauge IV and antecubital fossa. And notify the hospital, so take to stroke center if possible. The Cincinnati Pre-Hospital Stroke Scale, or the CPSS, is used to diagnose the presence of stroke in an individual if any of the following physical findings are seen: facial droop, arm drift, or abnormal speech. Individuals with one of these three findings as a new event have a 72% probability of an ischemic stroke. If all three findings are present, the probability of an acute stroke is more than 85%. Becoming familiar and proficient with the tool utilized by the rescuer's EMS system is recommended. Mock scenarios and practice will facilitate the use of these valuable screening tools. Individuals with ischemic stroke who are not candidates for fibrinolytic therapy should receive aspirin unless contraindicated by true allergy to aspirin. All individuals with confirmed stroke should be admitted neurological intensive care unit if available. The stroke treatment includes blood pressure monitoring and regulation per protocol, seizure precautions, frequent neurological checks, airway support as needed, physical occupational speech therapy evaluation, body temperature, and blood glucose monitoring. Individuals who received fibrinolytic therapy should be followed for signs of bleeding or hemorrhage. Certain individuals, age 18 to 79 years with mild to moderate stroke, may be able to receive TPA, or tissue plasminogen activator, up to 4.5 hours after symptom onset. Under certain circumstances, intra-arterial TPA is possible up to 6 hours after symptom onset. When the time of symptom onset is unknown, it is considered an automatic exclusion for TPA. If time of symptom onset is known, the National Institute of Neurological Disorders and Strokes, or NINDS, has established the time goals below. So within 10 minutes of arrival, the general assessment by an expert and order urgent CT scan without contrast should be done. By 25 minutes of arrival, perform CT scan without contrast, have a neurological assessment, and read CT scan within 45 minutes. Keep changing the slide before I mean to. Within 60 minutes of arrival, evaluate criteria for use and administer fibrinolytic therapy or clot buster. Fibrinolytic therapy may be used within 3 hours of symptom onset, 4.5 hours in some cases. And after 180 minutes of arrival, admission to the stroke unit should be performed. So take note, before giving anything, medication, or food by mouth, you must perform a bedside swallowing screening. All acute stroke individuals are considered NPO on admission. The goal of the stroke team, emergency physician, and other experts should be to assess the individual with suspected stroke within 10 minutes of arrival in the emergency department. The CT scan should be completed within 25 minutes of the individual's arrival in the ED and should be read within 45 minutes. So for ischemic stroke, confirm the time of symptom onset, perform targeted neurological exam or the NIH stroke scale, and complete Fibrinolytic Checklist. For hemorrhagic, consult neurosurgery and coagulation panel, type and screen. Then these will all lead to absolute exclusion, so head trauma in last 3 months, stroke in last 3 months, subarachnoid hemorrhage, arterial puncture in last 7 days, previous intracranial hemorrhage, active bleeding, heparin in last 2 days, elevated INR, hypoglycemia, very large brain infarction, multilobe, and platelets that are less than 100,000 mm3. Means no fibrinolytic. Relative exclusions means very minor or resolving symptoms. Seizure may be affecting neurological exam. Surgery or trauma in last 14 days. Major hemorrhage in last 21 days. And myocardial infarction is last 3 months. That also signifies no fibrinolytic. Inclusion criteria. Symptom onset within the last 3 hours unless special circumstance, 18 years or older, and ischemic stroke with neurological defect. And that would call for fibrinolytic. So for the acute stroke algorithm, first you need to have the important EMS assessment and actions, so complete pre-hospital stroke assessment, note time of symptoms onset, last normal, support ABCs and give oxygen, check glucose, titrate to stroke center, and alert hospital. Then you need the general assessment and stabilization. So evaluate vital signs, go through the ABCs, attain IV access, perform the lab assessments, obtain a 12-lead ECG, give oxygen if hypoxemic, check glucose, treat if needed, complete neurological screening assessment, order MRI of brain or emergency CT scan, and activate the stroke team. The neurological assessment by the stroke team should include going over patient history, complete neurological examination or CPSS neurological scale or HH stroke scale. Note the last known normal or symptom onset time. So if the CT scan displays hemorrhage, then see neurosurgeon or neurologist and transfer if not available. Admit to stroke or intensive care unit and start stroke or hemorrhage pathway. If it does not, so if the CT scan does not display a hemorrhage, acute ischemic stroke likely, or prepare for fibrinolytic therapy. Repeat neurological exam, deficits improving to normal. Search for fibrinolytic exclusions. If fibrinolytic therapy is still possible, then you're going to go over risks, benefits with patient and family is satisfactory. No antiplatelet or anticoagulant treatment for less than 24 hours and administer TPA. Start post-TPA stroke pathway. Admit to stroke or intensive care unit. Frequently monitored neurological deterioration and BP per protocol. If they are not a candidate for fibrinolytic therapy, then you're going to go ahead and give aspirin and admit to stroke or intensive care unit and start stroke or hemorrhage pathway. Don't forget, we offer online ACLS certification on our site. We encourage you to become certified as soon as possible, whether that be on your own time with an online course or in an in-classroom setting. So thank you so much for tuning into today's webinar. We will catch you the next time.